Hey, welcome everyone. We're here for another year, another wave. We're going to talk about lessons from the front line. First half, we'll be talking about rapid testing. Second half, we'll be talking about what's happening in medical and healthcare world. Our first speakers are here to discuss their very recent research publication, False Positive Results in Rapid Antigen Tests. We have Sonia Senek and Laura Rosella. Sonia Senek is Executive Director at Creative Destruction Lab. Sonia leads CDL's strategy, operations, and programs across 10 sites at University of Toronto, Oxford, Washington, Calgary, UBC, HEC Montreal, HEC Paris, UW Madison, Dalhousie, and Georgia Tech. Sonia is also Executive Director of CDL Rapid Screening Consortium, a nonprofit that delivers a free program to launch COVID-19 rapid screening in workplaces and schools across Canada. In 2020, Sonia founded the Sonia Rennick Resilience Fund, the largest multi-donor endowment in McMaster engineering history. We also have Laura Rosella, PhD MHSC, who is the principal investigator and scientific director of the Population Health Analytics Lab. She's also an associate professor in the Dalla Lana School of Public Health at the University of Toronto, where she holds Canada Research Chair in Population Health Analytics. She's a member of the Royal Society of Canada's College of New Scholars, the Stephen Family Research Chair in Community Health at the Institute for Better Health, Trillium Health Partners, the education lead for Temerity Center for Artificial Intelligence Research and Education in Medicine, and the Associate Director of Education and Training at the University of Toronto's Data Science Initiative. Dr. Rosella has had her research featured by several media outlets, including Forbes, Newsweek, Reuters, CBC, CTV, the National Post, the Globe and Mail, and the Toronto Star. They're both here to present their research published in JAMA. This publication is currently online as of just earlier this month, ahead of its publication, and thank you both for being here today.
Thanks so much, Krista. I'm just going to share my screen. Firstly, I want to say it's a pleasure to be here. Thanks so much to OHCOW OCAL for having us. I'm just going to share my screen and start taking us through a few slides, and then we'll take some questions. Laura, so I wanted to just provide context for the data that we have been studying for asymptomatic rapid screening across the country. We're not-for-profit. We run a program to support companies, not-for-profits, schools, to set up workplace rapid screening in their regions. When we started this journey about a year and a half ago, at the time there was very limited guidelines around the use of rapid antigen tests. So one of the key things we've done is help operationalize rapid antigen tests in partnership with the provinces, provide them with data, de-identified data, to show the outcomes from these pilots, to show how in practice the rapid antigen tests can be used as a layer of protection for mitigating workplace outbreaks. So the key operational design feature is that the data system facilitated provincial and federal reporting requirements. So if you were using our system, your reporting to the province and the federal government was taken care of. And all organizations agreed to share de-identified data centrally, which allowed us to leverage learnings from the cross-country data. So what does the CDL Rapid Screening Consortium do? We support the launch through three key pillars. One, on the left-hand side here, we provide training materials and standard operating procedures. As you know, many organizations, schools, not-for-profits, they've never had to have a virus screening program in their workplaces before. So we worked with our community to build best practices and continue to develop our SOPs and provide them, to the companies with training videos and that type of thing, a quick start guide. Second, in the middle here is the operational support and community building. We have a very active community on Slack. We have weekly operations meetings and bi-weekly town halls, really where the focus is on the people who are on the ground doing the work, learning and innovating on the fly, working with their communities, and coming and bringing their best practices and anecdotes back to the community. We also provide them with public health updates and economic updates, and we streamline the engagement with the provinces and territories. So if a guidance piece changes across the country, we can communicate it to the whole community instead of the entire community of 2,000 some odd organizations needing to go and outreach to the provinces and territories. The last piece is the data system to streamline reporting. Now, this was an essential backbone. Our KPI, our key performance indicator, we said was number of people regularly screened. We wanted people screening at least 2 times per week with rapid antigen screens so that it would be a layer of protection. We then de-identified that data so people could see at their home base sort of who in their team has screened, whether or not there was a positive and if they needed to manage it. But centrally, we just saw the de-identified data so we could see sort of trends across by sort of postal code. To give you a sense, we have, I mentioned, over 2,000 organizations. Of the types of companies that were using this, we have a handful of large corporations, but majority of our community is not-for-profits and small and medium-sized businesses, like birth centers, the Boys and Girls Clubs of Canada, Jay's Care Foundation, the Toronto Humane Society, a variety of veterinary clinics, small and medium-sized businesses like optical eye care or dentist clinics, some small manufacturing groups as well, and K to 12 schools across the country as well. And that spanned from public school boards, private schools, independent schools, Catholic school boards, all across the country. A key piece of how this data system was set up and how the system was set up is we have been breaking chains of COVID-19 transmission for asymptomatic individuals. So this system is set up for asymptomatic workers that feel fine or students that feel fine going in and out of their workplaces on a daily basis. We did not do the reactive use case of rapid antigen tests. So we did not use test to stay or test to work. We really were focused on the asymptomatic system, and that's what we've done. That's also the output of the data that we have is from the asymptomatic system. So just two more slides on what the actual data system does, and then I'll pass it over to Dr. Rosella. The data system was able to receive information from either an Excel template, a Microsoft-based app, or a standard app that was web-based, powered by a company called Thrive Health, all free of charge, so that a company could use a dashboard, as I mentioned, and manage its individual workplace. And then on the back end, we took care of provincial reporting. And on the back end, we also de-identified the data, brought it in with a connector code, put it, managed it with cybersecurity. And then we have our central data infrastructure where we could take sort of a map view of where the screens were being used and where the presumptive positive cases were. This is just to give you a visual of what does that web-based app look like. It looks like this. It's usable on any phone, tablet, or computer. Really simple interface where people could upload their results and upload a photo. So this was good for sort of checkpoints and compliance for any of the workplaces. Not that someone's sitting there all the time looking at the pictures, but you had the opportunity to do so to make sure that, number one, people weren't uploading pictures of their dogs or cats, or also that when they thought it was a negative, it was indeed a negative. So it was good for compliance as well as results checking. And then through the standard app, if there was a positive result or presumptive positive result, the individual would get a recommendation, of what to do next, what their next steps were. And our system was also able to confirm PCR tests as well. So if you had a presumptive positive, you could then later report a confirmatory PCR if you went locally and received one. On the administrator side, on the right-hand side of the screen, the administrator or manager at the office was also able to see immediately, okay, Susan screened positive, so you can make your HR planning and your operational planning around that knowledge immediately. So it's instantaneous. You can have that dashboard open all day long as you manage your workforce. Last point is just on the set of data, which was consistent across all of the regions across Canada. We worked on this data set with Health Canada and the provinces and territories. We set this about a year and a half ago, and it has not changed. We received the same data on any of the screens that were used over the course of the project. So I'm just going to pause there and pass it over to Dr. Rosella for the current data discussion.
Right. Thank you, Sonia. So I'll just quickly go over the data highlights from all this data that has been collected as part of this program, and then some of the interesting insights that have come out so far, and we're working on a few more. So the first is there have been over 1.6 million screens deployed across workplaces. You can see the graph on the right, the sort of coral line is screens administered. The black lines are regularly screened. So again, because we're focused on reducing transmission as a preventive, we were focused on screening at least 2 times a week. So we actually tracked how many individuals were regularly screening over time. And then of course, the presumptive positives, which tracked really well with the cases that we were seeing in the community and the subsequent waves that we saw. You'll see at the end, that big line, gray line up is Omicron. And we certainly picked up a number of cases, again, individuals that were feeling well, they were about to go into workplaces, where we had the opportunity to break a chain of transmission in that context. So this is just a view of the percent positive. So of the screens that we were being used and reported in the system, how many were showing up positive, and you can see it varied over time. But of note, very recently, we were seeing, 1 in 50, 1 in 40, very high, dramatic difference than what we've experienced since the start of the program to begin with. And that's really reflecting the Omicron surge. One other just really interesting turn of events, Sonia talked about all the benefits of the data system, which have been really critical. And when the PCR testing capacity system became very strained, we noticed that our data was also very useful for surveillance purposes. So we hadn't been using it primarily for that purpose. We had PCR testing data, really reliable PCR testing data. But what we've seen now is the percent positives that are picked up through the screening program actually reflect the epidemiology. And we don't have PCR tests to track this against because they aren't available for most of the people in Ontario right now, but we are tracking against other indicators like wastewater surveillance and showing that indeed is reflecting the epidemiology of what's happening in the community. So we're sharing this information with provincial tables, for example, to help inform modeling and situational awareness. So we want to just briefly, last couple of slides, talk about some of the insights we've gained and some of the analyses that we're doing. So first, we wrote up this experience of this large-scale implementation. Some really unique experiences include various workplaces. So very, very small workplaces, less than 5 employees, up to very large workplaces in all different contexts. So that was really important. How did we get everyone on board? How are we rapidly learning from each other? So that was important for us to really communicate, because I think going forward, this is a experience that's relevant for all types of workplace safety, not just responding to COVID. The other thing is we did observe over 480 people that screened positive. So those are chains of transmission that were broken. They were all PCR confirmed at that point, at the point we wrote this paper. And a very small number that screened positive, but were later PCR negative. Again, at that point, PCR confirmation was required for all because it was available. That requirement's since been lifted. So the point of that stat really also just relates to our next paper, was another research letter we submitted to JAMA on this. Initially when we were trying to support workplace implementation of screening, there was a lot of worry there was going to be false positive. And in fact, our data shows that, the false positives overall are very, very low. These tests are less sensitive, which is why they're used in a layered way. So they're a layer of protection with other layers in place, not as a diagnostic tool. But we did, so we were able to qual that with actual data, which really didn't exist because there hasn't been a systematic collection of data of a workplace program like this. But the other thing is we found a whole bunch of false positives in a cluster, and we were able to investigate it and tie it down to one particular faulty lot. Potentially faulty lots. There was something problematic. All these false positives that were coming up were all from the same lot. So there was a potential investigation. The point here is having a data system is actually really important to facilitate that. We otherwise would have never been able to stitch that together. And then the companies that were all working together and sharing with each other, they were across the country where this happened because screens were shipped everywhere. They were able to communicate and address this, and right away it was identified, moved on, and went right back to the program without any issues. So a high number of false positives like that without the proper investigation could have been really problematic, could have undermined the whole program. And so the importance of really understanding the impact of that data was really important. But overall, very low false positives, and no concern about disrupting workplaces unnecessarily. This is just another picture of the experience over time that we just want to share, showing the number of presumptive positives, and you can see how it tracked again with the waves. That, again, coral color of that 277 was that problematic lot that we were able to identify through our data system, and the Omicron wave at the side. Just see a picture of what we found in our experience in this program using absolute numbers. So we'll stop there. And Sonia, do you have anything to add before we turn to questions?
That's great.
I have a question. Do we have any data on the percentage of false negatives?
Yeah, I can take this one. So this was a program where if you tested positive, again, it was thought of as a screen, you had to go get confirmatory PCR testing. But PCR testing, these are asymptomatic individuals, was not available to anyone that was asymptomatic. So the negatives did not get PCR confirmatory testing. If we had set this up as a study per se, we would, arrange for everyone to get PCR testing. But because we were relying on public health guidance and these individuals are asymptomatic, the negatives couldn't get PCR confirmation. So we unfortunately do not have that information.
Okay, if anyone else has questions, they are welcome to either unmute themselves or type it in the chat. Oh, I see Kevin's.
Yeah, hi there. Thanks so much for the presentation and making yourselves available. This is wonderful. Just with regard to the new sublineage, kind of, so to speak, the BA2, and they're talking about it kind of being a stealth Omicron. So it's kind of talk about it evading PCR a little bit better. Is there anything that you want to add to that with regard to the rapid antigen test? Along the specificity and the sensitivity of the testing?
Yeah, this is a really great question. So actually, throughout the entire program, we've had new variants, and every time a new variant came up, we had to ask, are the rapid antigen tests still working? And so, this is the new subvariant, and we're still honestly waiting information on that of how the rapid antigen tests are affected. But for the most part, the rapid antigen tests work on the N protein of the coronavirus, and the N protein is much more stable. So the S protein, surface protein of the virus, undergoes a whole bunch of mutations, and the N does not. We have with Omicron seen some slight changes with N. That's kind of the first time. And so the sensitivity is probably dropping a little bit, but so far it is still picking up, as you can see by our data. It is still picking up on Omicron as well. But we have to go back to the manufacturers every time there's a new variant. They do some in sort of vivo testing, and then we also wait for some lab testing done by independent labs to verify that. But it's something we have to keep in mind every time a new variant comes. But this N protein being much more stable, and the fact that antigen tests work on the N protein, that's been very helpful, as opposed to PCR testing, which detects pieces of the virus, genetic material of the virus, sometimes can be more susceptible when we do see shifts like this.
Let's go to the questions in the chat then.
So Val, I put it in the chat, but Val asks, wondering how the program fits with the Chamber of Commerce system in Ontario. Is it different or behind it? Are you having supply problems? So I'd say the CDL RSC is a complementary program to the Chamber of Commerce. Chambers have been supplying screens. They've been given a supply from the province and then sending it out to workplaces. So that's supply. CDL RSC, what we do is we help train the workplaces and provide them with the free data system and operational support to use the screens. So very much working hand in hand and supporting all of the chamber programs, actually across the country as well. Chamber of Commerce in Calgary, ones in BC and Manitoba and Saskatchewan as well. And then Lynn asked, did you speak about the nasal swab versus pharyngeal sampling and perhaps sampling both to increase sensitivity? Laura, I'll just pass that over to you.
For sure. So certainly there have been some moves to do oral nasal sampling, always nasal, but now including also an oral sample and nasal to increase sensitivity. Nova Scotia has recommended this. It is not what the tests were approved for, and the manufacturers are concerned about some risk. Self-swabbing your throat's actually very difficult. So an oral might be better, but it's a whole different ballgame than sort of self-swabbing your nose. So that's why there's been a bit more hesitation. That being said, if a province has a recommendation, even though it's not what it was approved by Health Canada, it can be used that way. So this is about keeping an eye on which province you're in, and if that province has issued formal recommendations that you can use it as an oral nasal. And currently, for example, in Ontario, that hasn't happened, but I believe it might. And it has happened in Nova Scotia. So that's where that's at. It is much easier if someone is doing it, but then that changes the whole use of it.
And then Mark asked, all the rapid tests were the same brand, ? Were there other concurrent studies doing the same thing, but testing other brands So I'll say that of that data set, there was actually 2 brands at the time. One was BD Veritor and one was Abbott Panbio. Laura, do you want to speak to the concurrent studies?
Yeah, those 2 studies were those specific ones, but in terms of whether or not there are other brands, there are lots, and there are many getting approved. And in terms of distribution in Canada, they might be any of them. Now, we do see variation across different brands. What I will say is for the brands that are approved in Canada, generally speaking, they're the same. In Europe and the US, they do have some other brands that have poorer performance, but those aren't used in Canada. So for the most part, for now, this might change. The brands that are approved are all quite similar. We've looked at the performance across brands and they're all quite similar.
Next is, Laura just mentions, what recommendations does anyone have for getting the rapid antigen test? They seem to be hard to find, shortages. Is that the reason? So Laura and also Val touched on this. Yes, there have been supply delays. We've seen that across the country over the last several weeks. We do know that the federal government's placed a very large order, and the provinces, on behalf of the provinces. So we anticipate in the next few weeks for some of the non-prioritized workplaces in Ontario starting to receive screens again, but they are being prioritized right now for high-risk settings. Laura, anything to add on supply or prioritization?
No, other than, I think supply is coming and there's a big push to prioritize for, hospitals and schools, which make a lot of sense. I think there does also need to be streams approved for, workplaces, which are a critical part of our community, and making sure workplaces are safe. So I think that those are in discussion. One of the big challenges here is because PCR capacity got so constrained, people started turning to rapid antigen tests in a diagnostic capacity, which comes to Val's question, so maybe I'll answer it now. So they started thinking about use of rapid antigen testing for diagnostic purposes because they can't get antigen tests. So even further straining the system. But I think as we start stabilizing a bit, using PCR tests, sorry, there's echo, using PCR tests in the context of asymptomatic screening versus test to stay, they'll sort out where the actual priority should be. So that's part of the reason why. The supply, I think, is coming. I think the question is going to be how provinces are going to prioritize how they're going to give them out, which at this point is high risk settings, healthcare, and maybe schools. And we have yet to hear consistently what it'll look like for workplaces. Can I just I'll just take Val's question now as well, which is about using tests to go back to work. And again, that wasn't the focus of our program, but I think it's important to talk about that it is a whole different ball game, right? So using it as a layer of protection to keep workplaces safe, we think has clear benefits. When you're using it to rule out infection, it's not as sensitive of a test. So it can be risky. And generally speaking, you have to do it only under very careful guidelines. So there'll be guidelines offered by either local public health unit or the province on how you actually do this. And so they would say after 5 days, this is an example, if someone's symptom-free, they need 2 negative rapid antigen tests at least 24 hours apart. That's one example of it. But my message to everyone is just, it is a much more risky and careful, you have to use these tests in a careful way. And you probably need someone that understands the context you're in. Are you in a high risk setting? Are you seeing high risk individuals? And are you still symptomatic? The UK, for example, was doing 7 days, and then on day 8 and 9, 22 negative rapid antigen tests to come back, which probably I think is maybe a little bit less risky, as many people can still be infectious after 6 days. So I'll just say it's a very different ballgame. And I think that's been one of the challenges. These are very useful tools. Using them as a layer of protection, knowing that there's going to be other layers as well, and you're using it as a preventive is one thing. Using them in the context of bringing someone potentially infectious back to work needs to be done very carefully. So that's my message, just to understand that these are two different use cases for this particular tool.
And I see Nick in the chat had asked what percentage of your partners provided paid sick or isolation leave. Did you track that?
went to Paris after 2 years. I came here, before going, I tested 2 PCR, 2 antigen negative. I go to Paris. My younger sister was with me in the apartment in Paris. She did not test. She tested negative. I go for PCR and I tested positive. I came back, I went there a week later and I tested negative both, PCR and then antigen. And the antigen, I did it like on a Sunday because it was you know, like a pharmacy was open on Sunday. You know, in France, nothing is open on Sunday. And I was very happy to come back to New York. What is this PCR and antigen? One day you are positive, one day you are negative. I don't understand.
Yeah, so PCR is a totally different test. So PCR tests the remnants of the genetic material of the virus in your system. It's much more sensitive and much more significant, specific, which is why we use it for diagnostic testing. So if you are symptomatic, the PCR test is what you should be using because it's used for diagnostic purposes.
I was not symptomatic.
Any discrepancy between the two is really about the different performance characteristics of the virus. It can fluctuate over time. Certainly a PCR will stay positive way sooner and it'll stay positive way later. There's only a short period of time when a rapid antigen test will pick it up. And that period of time is generally when you're likely to be infectious. So you can have diagnosed with COVID, the PCR will pick it up sooner and later. And that's why we don't use it for diagnostic. We're using it as an indication that you might be infectious and that you might expose to other. They're not the same test. They have different performance characteristics, and the timing of when you take that test relative to your infection will produce different results if you do these two tests.
We're going to have to end the questions there. The next session, Denise, might help you out with that a little bit more, but Dr. Rosella and Sonia have another engagement they have to get to. I want to thank you.
Depressing.
Yes, it is interesting. Thank you very much, Sonia and Dr. Rosella, for presenting your research. We really appreciate that you were able to be here.
Thank you for having us.